Neurological problems. This will be a lecture in 3 different parts. Keep in mind that your 80% of your cranium, your skull area, is taken up with brain tissue. 10% is blood and another 10% is cerebral spinal fluid. Increased intracranial pressure is the leading cause of death due to trauma. Intracranial pressure will increase if you cough, you sneeze, you laugh, you bend over, that sort of thing. And you need to follow the following for your assessment: cotton, flashlight, newspaper, ophthalmoscope, otoscope, reflex hammer, safety pins, Snellen chart, tape measure, tongue depressor, tuning fork, objects of different shapes such as marbles, coins, the key, stoppered vials that contain coffee and peppermint for smell, salt and vinegar for taste, and hot and cold water for temperature. Your reflexes are scored 0 to 4%. We have 12 cranial nerves. You need to know what they do. You need to know what they're responsible for. Your cerebral cortex is responsible for your awareness, accuracy of movement, balance, gait, rapid alternate movement. Your hypothalamus is responsible for your temperature regulation, autonomic nervous system reaction, food and water intake, control of the pituitary gland, and behavior. It's considered your master gland. You need to know the different lobes of the brain and what they're responsible for, such as frontal is responsible for your thinking, occipital for seeing, temporal for temperature and hearing, that sort of thing. You need to know that the midbrain is responsible for your reflexes, your biceps, triceps, patellar, and Achilles reflexes. And your brainstem is responsible for your respirations and your circulation. The blood supply to the brain is supplied mainly by the circle of Willis at the base of the brain and your carotid arteries, carotid veins. You need to be aware of that. And that there are ventricles in the brain that can be affected. And the spinal cord. And what goes wrong when the spinal cord has a problem. So, this is a way to remember your cranial nerves. One way is to say, some say on the far right, some say marry money, but my brother says bad business marry money. S meaning sensory, M meaning motor, and B means it does both. In the middle, you've got your on old Olympus towering tops, a Finn and German viewed some hops. The first letter indicates which nerve it is so that you can get the different nerves that they are there. And this is from the memory book. So, you need to do a history. What caused this? When did it start? How did it start? What's going on here? You need to know, are they oriented to person, place, and time? And keep in mind that it's not always in that order. Sometimes they don't remember who they are, but they know where they are and when it is, or vice versa. So don't just use the initials without knowing what it says or saying what it means. You need to be able to assess their attention, concentration, their ability to calculate, their memory. For example, you can have them count backwards from 100, subtracting 7 each time, as long as you can do that. Subtracting 5, as long as you can do that. I mean, that's up to you what you have them do backwards, but it does help with their memory. Or you can give them a list of words and have them repeat them to you. And their mentation, their logic, and their judgment. You need to assess their level of consciousness, and that ranges from alert all the way to comatose. So they go alert, drowsy, lethargic, stuporous, obtunded, and then comatose. Alertness is the level of orientation. If you have a problem, patient's having a problem neurologically, you need to do the Glasgow Coma Scale. Glasgow Coma Scale has a maximum score of 15. A score of 7 or below means they're in coma and probably should be vented. You cannot use the Glasgow Coma Scale as done with children, alcoholic, somebody who's drunk, or someone who has a spinal cord injury, because they will not respond appropriately to the questions. And remember, too, that your reticular activating system is responsible for your level of arousal. I think I forgot to say that. You need to assess motor function. Do they follow commands? Can they respond to noxious stimuli? Is there abnormal posturing? Strength reflexes, like grasp or Babinski. Your motor function includes your muscle tone and your strength. Your abnormal posturing is like decerebrate, where everything is extended, your arms and your feet. Or decorticate, where the arms come in toward the core and the feet are still extended. Or lateralizing, where it affects only one side. Contralateral hemiparesis is from compression of your corticospinal tracts. In other words, you have damage on one side, but the other side is weak. If you have decerebrate, you have damage close to the midbrain or the pons. Decorticate, you have damage to your corticospinal tracts. So that, you bring that into your core. Lateralizing, again, is the difference between right and left, and it increases your risk for herniation. The grasp reflex in the adult is abnormal. It means you put your fingers in their hand and they grab hold on it. That's abnormal. That means they have cortical damage to their cerebral cortex. A Babinski in someone over the age of 2 indicates an upper motor neuron lesion. Under the age of 2, that's totally normal because their neurological system is still developing. A positive Babinski is where you stroke the bottom of their foot with a sharp object, and the toes flare and the great toe abducts. So it like points towards your nose, and the toes otherwise. Usually a negative Babinski is when you do that and everything curls in. You need to assess their pupils. Pupils should be equal, round, and reactive to light accommodation. That's what PERLA stands for. Keep in mind that pupils can be 1 millimeter different and still be normal. Look at Sam up in the HPS lab. One pupil is 3 and the other one's 4, or one's 2 and the other one's 3. There's always a millimeter difference. Your pupillary dysfunction can assist you in identifying the presence and location of dysfunction. If you have an ipsilateral pupillary dilatation with a sluggish reaction, that means you have compression of your third cranial nerve. And ipsilateral means it's on the same side as the injury. It will become fixed if it's not treated. If your pupils are constricted, you have a problem with your parasympathetic system. If your pupils are dilated, it's the sympathetic system that's involved. If they react slowly, you have a brainstem injury. And if they're oval, you have an increased intracranial pressure. It's above 18, because your normal ICP is 5 to 15. You need to check for eye movement. Now, Dahl's eyes is when the eyes go in the opposite side when the head is turned. In the unconscious patient, this is normal. If they don't do it, there's brainstem injury. The cold caloric test is where you instill 20 to 100 milliliters of ice water into the ear. The eyes will turn toward that ear. That's good. If they turn away, that's abnormal. If there's no reaction, there's no brainstem activity. The cold caloric test is performed by a neurologist or a neurosurgeon, not by the nurse. But they do really use ice water. I mean, I've actually seen ice floating in the water when they do this. You need to assess respiratory pattern because the respiratory pattern may tell you what's going on. Is it Kussmaul's? Is it Cheyne-Stokes? Whatever. You need to check for a cough, gag, or their swallow because those will change with an increase in intracranial pressure. You need to check your arterial blood gases and your SaO2 level because if you're those are out of whack, that will make a difference neurologically. They're vital signs. If your blood pressure is increased, it will increase intracranial pressure. If it's decreased, it tends to indicate a terminal event. So it's not a good thing. Your mean arterial pressure has to be at least 70 to have adequate cerebral perfusion pressure. And your mean arterial pressure is your systolic plus twice your diastolic divided by 3. That's the easiest formula I've seen out there. There are other formulas you can use, but that one works really well for me. Your cerebral perfusion pressure is when you take your mean arterial pressure minus your ICP. So, if your ICP is 10, that's halfway between 5 and 15, and your mean arterial pressure is 70, then your CPP is 60. You need to know your heart rate and rhythm, your respiratory rate, your pulse ox, the end-tidal CO2, pulse pressure and temperature, because all those abnormalities think something else is going on with your patient. And I'll talk about those in just a moment. Cushing's triad is where you have bradycardia, an increase in your systolic blood pressure, and a wide pulse pressure. Subtract systolic from diastolic. This indicates that the brain is starting to herniate because of an increase in intracranial pressure. Cushing's triad is a late sign. It is not a sign you want to ever see. Intracranial pressure, you need to know what it is. If it's increased, the first symptom will be a change in your level of consciousness. It doesn't mean coma. It could mean restlessness, anxiety, forgetfulness. Then they'll start to have a worsening headache, pupillary dysfunction, blurred vision, weakness, nausea, vomiting, alteration in their vital signs, and a change in their respiratory rate and rhythm. Keep in mind, for the first 2 stages of increased intracranial pressure, there are no obvious signs except for that change in the level of consciousness. It takes a very astute nurse to pick up on it then, because that can help prevent future problems for your patient. The pathophysiology of problems neurologically depend upon the area of the brain that's involved. Remember, if there's damage to the midbrain, you'll have loss of reflexes. If it's to the brain stem, you'll have loss of your respiratory and circulatory control. And if it's to your frontal lobe, reasoning and logic. Occipital sight, temporal, temperature sense, hearing, position sense, that sort of thing. This is a diagram from the memory book that's showing different signs of abnormal posturing. You've got your decorticate on the far left, you've got your decerebrate in the middle, and flaccid on the far right. Causes of changes in your level of consciousness. Now we already know it could be decreased cardiac output and it could be hypoxia. But as far as neurologically, it could be due to trauma. They could have a concussion, which is a brief loss of consciousness due to a severe blow to the head. Or a contusion where the brain is bruised and you're going to have loss of consciousness for more than 5 minutes. Means they need to go to an ER. Concussion, not necessarily, but contusion very definitely. A hematoma is accumulation of blood in or around the cerebrum, and it acts as a space-occupying lesion and can kill due to causing a herniation. So it's something that needs to be treated. Different diseases such as infection, neoplasm, seizure, or Alzheimer's can cause changes in your level of consciousness. Systemic conditions such as diabetic ketoacidosis, HNS, or hyperosmolar hyperglycemic non-ketotic coma, or syndrome. Acid-base imbalances, or electrolyte imbalances. Drug toxicity, such as alcohol or drugs, could also cause changes in your level of consciousness. So, a concussion is a loss of consciousness lasting seconds to hours. If it lasts 5 minutes or longer, they need to go to the hospital. Symptoms are confusion, disorientation, amnesia, headache, dizziness, nausea, and inability to concentrate. Fatigue. My brother-in-law was driving home from work. He works over at Davis-Besse, and he had been working nights, and he was really, really tired, and proceeded to go through a stop sign and get broadsided by somebody in a brand new pickup. The brand new pickup was totaled, but the person inside was not injured at all. Frank was hanging upside down from his seatbelt because his car was upside down until they could get him out, and he definitely had a concussion and probably even a contusion. He was life-flighted to V's, And this is when I found out for the first time that if you ever have to shave anybody or remove their hair, you can only do it around the area of injury without their written consent, because he had a laceration of his right eyebrow above his left lip and his left part of his chin. And so they shaved half his eyebrow to put in a suture. He had a mustache. They took half the mustache off to shave that. And he had like a little beard, and they just shaved around the area of that. It looked a little strange for a while. He also had contused kidney and pelvic fracture, and was in Neuro ICU for about 3 days. They were very kind, very smart, very caring there. And then he went to the step-down unit, and they put him on the orthopedic wing, and they wouldn't tell us anything without a written doctor's order. And that's not allowed. I mean, if Frank said, tell my wife, they had to tell his wife, because I would give her lists of things to ask for, because I'm a nurse and she's an accountant. And so we had to go to his primary physician, and they had never even called to tell him he was in the hospital. St. V's had not. So we told him, and he went up to see Frank, and he wrote an order so that she could know his vital signs, his lab work, anything she wanted to know. So that helped. The other thing that was wrong is with a fractured pelvis, you want to get up and walk to put pressure and push calcium into that bone to help heal. With a contused kidney, you have to be on complete bed rest. And so we had 2 physicians not talking to each other and nurses not talking to either one of them. In fact, one time he went for a cysto, and nobody even knew where he went from the orthopedic wing. The problem is St. V's has like 5 operating areas, so they really didn't know which one he went to. Sad. That's the problem with the medical center. But other than that, he got excellent care, and Frank's doing just fine. Contusion is a bruise of the brain, and that bruising will cause hemorrhage in the frontal, temporal areas, depending on where it occurs. Now, the coup is the site of the injury. The contra-coup is on the opposite side of the injury, and oftentimes it's the contra-coup injury that kills the patient, because that continues to bleed and nobody knows it until it gets severe enough that they have to do something about it. The contra-coup injury can increase the area of damage over 2 to 3 days. So can the coup, but with an increase in intracranial pressure. Temporal lobe edema will affect the midbrain. These patients will deteriorate rapidly, and it takes about 3 to 5 days to evolve, and they do require surgery the majority of the time. This is diagnosed with a CT scan. But it's really important for you to assess vital signs and their pupils. This is from the memory book showing different types of head injury. It's really important that you check those pupils every 2 hours after a head injury. Spinal cord injuries are classified according to their extent. In other words, is it a fracture or a dislocation of the vertebral column? They want to know the level of the injury. Is it cervical or thoracic or lumbar? How many cervical vertebrae do we have? Hopefully you said 8. So if the level is between C2 and C3, they'll have respiratory paralysis and they'll be quadriplegic. If it's between C5 and C6, they'll have diaphragmatic respirations. They'll still be a quadriplegic, but they won't necessarily need to be on a ventilator. Where C2 and C3, they will need to be. At C5 and C6, their shoulder girdle will still be intact, so they'll have some upper body movement. How many thoracic vertebrae? Hopefully you said 12. If the damage is between T1 and T6, they'll be paraplegic. You'll have loss of everything below the mid-chest. If it's between T6 and T12, you'll have loss of everything below the waist. If it's between T12 and L1, you'll have loss of sensation and control to the legs and pelvis. They'll still be a paraplegic. How many lumbar vertebrae? Hopefully you said 5. And if the problem is between L4 and L5, they'll have loss of motor and sensation to the lower legs, ankles, and feet. It's called an incomplete paraplegia, so sometimes they can wear braces and walk. They need to know the mechanism, what caused this. If it's hyperflexion, this is a forward dislocation. Hyperextension is where you rupture the anterior ligaments. Axial loading is a vertical compression type accident, usually a diving accident. And flexion rotation is where you bend and turn the head at the same time. You need to know whether it's complete or incomplete. If it's complete, all motor and sensation function is lost below the level of the area of the injury. If it's incomplete, only on the one side, the opposite side of the injury. Transection or partial transection. Now, a transection, again, is tearing of the cord from side to side. And you need to know about that. You all know, I hope you do, about Christopher Reeve. He played Superman in the movies, was on a horse doing a jumping competition and landed on his head. Fractured C2, C3. Had somebody not been there to know CPR, he would have died at that time. But they knew CPR. He ended up being on a ventilator for, 10 to 15 years, I'm not sure, in a wheelchair. But prior to Christopher Reeve's accident, everything we did as healthcare professionals, nurses, physicians, physical therapists, everyone, was to try and teach the patient to live with that injury. Once Christopher Reeve was injured, he was determined to walk again. And so then, and he had some very influential people and some people with money behind him. And since then, research has exploded on how to get the spinal column to regenerate. What can we do? They've tried TENS units, they've tried stem cells, and there is some possibility that stem cell injections will do some good there. And they're looking at stimulating below the area with the TENS unit, the area of injury, and that may help. So since Christopher Reeve, people are actually looking at ways in which to improve neurological function and the ability to walk again. He actually was able to walk a few steps by being in a special brace with a special treatment, and he was only able to do it one time. But normally patients who have a fracture at his level of the spine are 100% vent dependent. He was able to train himself so he could be off the ventilator for 90 minutes a day, once a day, which is phenomenal. It really is. This is from the memory book, talking about the different levels of the lumbar, thoracic, cervical, and sacral. I didn't mention sacral, but spinal column. And this is looking at spinal cord injury, again from the memory book. Temperature regulation below the level of the injury is a problem. And also, if you have a head trauma and you get spinal cord injury, head trauma, and you get a fever, that's always a very bad sign. It's usually a terminal event. So spinal cord injury, again, you're quadriplegic if the damage is anywhere between C1 and T1. You're paraplegic if the damage is between T2 and L2. We talked about Christopher Reeve with quadriplegia. Joni Mitchell also had quadriplegia, but she had some spinal shoulder girdle movement and is able to be a painter and has painted some beautiful pictures with that. Leonard Stabb was an actor who was hang gliding, and he's still in, I haven't heard how he's been doing lately, but he was in a persistent coma following his head injury and his spinal cord injury. Incomplete spinal cord injuries, such as Brown-Sequard syndrome, this is also called lateral cord syndrome. This is where only one side of the body is injured, and you end up having one side of the spinal column is injured, and you have loss of voluntary movement on the injured side, and pain and temperature and sensation on the opposite side is lost. Central cord syndrome is you have a problem in your upper extremities, more so in the upper extremities, because it affects the centermost fibers that are responsible for respirations and upper extremity movement. And this is usually due to a hyperextension injury. Your incomplete spinal cord injury depends upon the area of spinal cord that was involved, and there is a table on page 1597 in Lamone that talks about comparison of the different types of spinal cord injury, because there are some more. We have our anterior cord syndrome, which is due to flexion injury with forward dislocation or subluxation. You'll end up with decreased function, pain sensation, and temperature below the area of the injury. That'll be lost. You'll have position, pressure, and vibration sensation that's normal with an anterior cord. With posterior cord, you'll have a decrease in your position sense, your pressure sensation, and your vibration, but your movement, pain sensation, and temperature are all normal. Now, spinal shock is due to the edema at the site, causing a decrease in function below the level of the injury, usually total paralysis. And if you position your patient differently, it can cause hypotension. This usually takes weeks to several months to resolve. As I said, it can cause hypotension, bladder and bowel distension. But spinal shock will resolve when the edema disappears. Indications that it is resolving is a return of your reflexes, muscle spasms, and reflexive emptying of the bowel and bladder. Autonomic dysreflexia or hyperreflexia is an abnormal reaction to sympathetic stimulation due to bladder distension, obstruction, infection, spasms, catheterization, bladder irrigation, bowel constipation, impaction, rectal stimulation, alteration in skin integrity. If it's untreated, it results in a stroke, retinal hemorrhage, or seizure activity. And we need to not do that to our patients, so we need to pay attention to them when they say something doesn't feel right. Usual cause is constipation and or pressure ulcer. And this is again showing autonomic dysreflexia, what causes it, and what can lead to that. And this is where we're going to stop part 1 of our lecture.